of Emergency Medicine, Drexel College of Medicine, the Center for Nonviolence and Social Justice, and also the Public Health and Pennsylvania Public Health Training Center, both in the School of Public Health. Today we're going to learn about the intersection between public health and medicine and how it influences our practice, as well as the health of the population. Today, we'll hear from an esteemed colleague, Dr. Michael Greenberg, discussing yet another relevant topic that crosses the fields. Rabies, a paradigm interface between public health, public policy, and emergency medicine. Most of you know Dr. Greenberg, but just to give you a little more info about him, he's a tenured professor of emergency medicine and professor of public health at the Drexel College of Medicine and Drexel University School of Public Health, respectively, in Philadelphia. And he's also a clinical professor of emergency medicine at Temple University School of Medicine. He's chief of the Division of Medical Toxicology, and he's board certified in medical toxicology, preventive medicine, and emergency medicine. It's my pleasure and honor to welcome Dr. Michael Greenberg.
Well, I'd like to start out by saying hello to everybody and thanking Ted for asking me to do this. It's always great to do a lecture like this because it gives you a chance to learn a topic in depth, and I would encourage any of you that when you get a chance to pick a topic you like and learn about it and get to the point where you can give a lecture. It's like the old see one, do one, teach one. You really don't know the topic until you get to teach it. So it's fun to do this. Speaking of knowing topics, and I'll use this as a lead-in to the fact that the title of this talk, I tried to blend public health and emergency medicine. And I've always said that emergency medicine nowadays anyway is the clinical practice of public health. Anybody who works in the ED knows that. And we're called upon to do so much public health type work that it's actually easy to find crossroads where the two specialties or the two areas of endeavor cross over. But I don't know if any of you are students of Sir William Osler, and he once said that he who knows syphilis knows medicine. It's kind of a weird way to think about medicine, but back in the day when syphilis was so prevalent and such a multi-system disease with not good cures, and there were actually venereologists and syphilologists, people who actually studied syphilis. And they were the quintessential internists. They knew all about medicine. And in an analogous way, I think that if you know rabies, you can begin to understand public health in the United States today. There's some very interesting things that I'm going to talk about with regard to rabies and public health, and hopefully you may come to believe this by the time we're done talking. So today I just want to go through a sort of a brief historical perspective about rabies for you, some epidemiology, which is extremely important for folks in the emergency department to know about, a little bit about rabies transmission and pathophysiology. I'm going to touch on the clinical issues. The clinical issues are wide-ranging and they're very complex, so we're not going to go too far into that, but again, to help keep it relevant for the folks who work in the ED every day, I want to go through some important points, especially since yesterday I saw someone in an ED for their 5th rabies post-exposure prophylaxis that they didn't need. So I'll tell you about their case when we get to it. And a little bit about prevention and control, and that's an extremely important issue as well. So as far as the historical perspective, some of you, especially the folks from the public health world here, may not know that rabies was actually the earliest public health measure ever formally addressed. It was found itself in the Mesopotamian laws of Ashunanim. And that's what they used to call you Ashunanim in college, didn't they, Ed? No? Okay. This was before 1800 BC. And it called for the mandatory extermination of infected animals in the community with some compensation for anybody who was bitten by the infected animal. So the concern about animals, public health, and rabies goes way back. A little bit further on in history, Celsius, in about 30 AD, recognized the nature of rabies and the fact that it was transmitted by saliva, particularly from dogs. And he recommended such things as cupping and cauterizing wounds, He also suggested something a little weird, placing the patient in a river or lake head down until he cannot avoid swallowing water. Now, we've all felt like doing that to some of our patients in the ED, but we don't do that anymore. And being a good scientist, he must have found that this didn't work, and he later sort of revoked this recommendation, thankfully. Around the Middle Ages, people just decided, well, they're going to pray about this, and they turned to the patron saint of hunters, Saint Hubertus, and they were very freaked out about rabies because the death was so horrible. And they tried all sorts of things, potions and purging, bleeding, and all sorts of herbals, and obviously nothing worked. In 1546, a physician actually described what is really the classic case of rabies, and I'm going to read this to you because it still applies today. The patient can neither stand or lie down. Like a madman, he flings himself hither and thither, tears his flesh with his hands, and feels intolerable thirst. This is the most distressing symptom, for he so shrinks from water and all liquids that he would rather die than drink or be brought near to water. It is then they bite other people, foam at the mouth, their eyes look twisted, and finally they're exhausted and painfully breathe their last. Pretty dramatic description of the rabies death, but it's not off the mark. This is what rabies death looks like. Moving on into the 1800s, the biggest advance probably that was ever made in rabies up until the time was Louis Pasteur, who actually developed a post-exposure prophylaxis that worked. I'm not going to go into the whole history of that episode, but that was sort of the last major hurdle in the battle against rabies for a long, long time. And Louis Pasteur should get a lot of credit for developing this concept of post-exposure prophylaxis for rabies. So the epidemiology, and this is actually where the rubber meets the road for everybody, for public health and for emergency medicine. You've got to know the epidemiology, and you've got to know the epidemiology locally where you're working. So I'm going to talk a little bit about the Pennsylvania epidemiology of rabies, because I think we all need to know that. But we're going to talk about international issues, and we're going to talk about domestic issues as well. I know, interestingly, when we interview people for EM residency, every person, just about to a person, says, well, they're interested in international emergency medicine. Do we do international emergency medicine here? Well, the answer is yeah, to an extent, but rabies really speaks loudly to international emergency medicine. There are probably more than 60,000 cases of rabies, human rabies, annually worldwide. That's an enormous number. We don't have that in the United States. That's going to be a focus of what I want to talk about a little bit later, but that's an amazing burden of disease internationally. The highest incidence is in Asia, and the death rate is enormous, as you can imagine. Over 10 million people in the world receive prophylaxis annually at a cost of more than $56 million. So it's an incredible international cost in money and in lives. In the United States alone, 15,000 to 40,000 people receive prophylaxis every year. And if you divide that out, there's, I don't know, 5,200 EDs in the country or something. So that's 7 or 8 people per ED that are getting prophylaxis per year, which means that it's incumbent upon you guys to know how to do that prophylaxis, post-exposure prophylaxis. It's incumbent on the hospitals to have the correct pharmaceuticals available, and yesterday I took a flyer and I called the pharmacy to see if we have all the appropriate pharmaceuticals for post-exposure prophylaxis, and we do. So I was happy to see that. The differences between the rabies epidemiology in the United States and the rabies epidemiology around the world is very important, and I want to just sort of get into that a little bit. And the differences are based on some of the things you would imagine: socioeconomic status, accessibility to effective post-exposure treatment. Certainly there's a difference in number of deaths and specific reservoirs. We'll talk about that a little bit more. And evolution of public health services. So there's lots of places around the world where public health simply has not evolved to the point where it's even beginning to address rabies. And there are other issues as well. But the distinction between what goes on in the United States and elsewhere is profound and is going to change. And I'm going to talk about that a little bit. In the United States, more than 90% of all animal cases, and when I talk about rabies, I'm trying to clarify if I'm talking about human rabies or animal rabies, because they're two different issues in a sense. But most animal rabies in the United States are in wildlife as opposed to domestic animals. Before 1960, the majority was in domestic animals, dogs and cats. Today, most animal rabies are in wild carnivores and bats. And rabies-related deaths in the United States have gone down enormously from more than 100 a year at the turn of the last century to maybe 1 or 2 or 3 a year currently. But again, that's about to change, and that's really the focus of my talk today, why it's going to change and how it's going to change and how it's going to affect all of us. And as you can see, I mean, we're not immune from some unusual things happening in this area. I mean, this is just in June, this headline here, bizarre rabid fever attacks Philadelphia park patrons. I don't know if you remember that on the news. And even out where Dr. Roberts lives, or used to live, Radnor Township in 2009, concerned about rabies in the fox. And these things are constantly coming along in locales where you may not expect it. And this is a map from the CDC showing rabies cases that were documented by state of animal rabies. And as you can see, there's a preponderance in the Northeast, especially in Pennsylvania, where we are. But there are no states in the continental United States that don't have animal rabies. The only state in the union that has not reported animal rabies is Hawaii. Jolene, probably want to go back as soon as you can. And this map shows a little more graphically the constellation of cases of rabies. This is way back in 2001. But you can see that they're grouped in the Mid-Atlantic states and the Northeast as far as numbers in animals. And the distribution of the reservoirs is interesting. In the Northeast, it's mainly raccoons. Other parts of the country, it could be skunk. But again, the animals don't read these maps, so, you know, rabid skunks go east and rabid raccoons go west, and there's certainly a tremendous mixing, but you need to have your antenna up if somebody says, I was bitten by a raccoon, or any of these animals, for sure. We'll get into that. So across the board since the 50s, the case of animal rabies in total and in wild have really gone up. And the cases in domestic animals have gone down. Now, this is very important, and this is a reflection of a bunch of things. Primarily, great veterinary care and the fact that there's a preponderance of vets out there, and people tend to take decent care of their pets and take them to the vet for visits on a routine basis. Sometimes they take better care of their pets than they do their children. But this is a bit of a tribute to animal control laws and the veterinary community. And this is a problem that is about to get worse, and again, I will get into that in a few minutes. This is an interesting graph. This is the number of human cases of rabies, and that's the number of cases in animals. And this mustard-colored line down here shows you the human cases in the U.S., and you can see wild animal cases have increased, domestic animal cases have gone down, and human cases have gone down until the early 2000s. And again, that's about to change. I'll get to that. Rabies around the world is different, very different. Exposure to rabid dogs is the cause of 90% of human rabies in the world, and greater than 99% of human deaths worldwide. There was just a death in a soldier from the 10th Mountain Division, who was based in Fort Drum, New York, who just came back from Afghanistan, and while he was deployed, found a puppy and, you know, took the puppy in and was feeding the puppy and taking care of him. The puppy bit him, and by the time he got home, he was showing manifestations of rabies, and he died recently. And I'll use that as a segue for an advertisement to everyone in the room to subscribe to ProMed. This is a service that's an informal worldwide service of epidemiology and mostly infectious disease issues, although there are some chemical issues that they discuss. And they send you a million emails, and it's annoying. You delete most of them that you're not interested in. But you do find some interesting epidemiology in there about cases that are going on in other parts of the world. And with the translocation of populations, you can see one of these cases in the ED, and knowing about it is a big help. The other advertisement that I'd like to put out there is everybody in this room should be reading MMWR. I mean, that's where you really get good information about what's going on in the United States. Again, not every article is going to be interesting to you, but it's got plenty of really important information. When immunization recommendations change, and when epidemiology changes, it's in the MMWR first. You can get online free, and it's a great publication. I recommend it to everybody, and especially the emergency medicine folks who tend to not to pay attention to this kind of stuff, but I think they need to. So most deaths in countries, current countries with very poor public health facilities and infrastructure, few diagnostic abilities or facilities, and no rabies surveillance. This is more the rule than the exception in most of the developing world currently. Rabies is a so-called sylvatic disease with the vectors being wild animals. And worldwide, the wild animals are foxes, wolves, raccoons, bats, monkeys, jackals, etc. Almost any mammal can carry rabies and transmit it. But again, as I said before, on a global basis, dogs are the major reservoirs. So bites from rabid dogs actually cause tens of thousands of deaths per year, and they prompt prophylactic treatment in millions of people. So you see somebody who just came back from, some ecotourism thing, and they were bitten by a dog, and they came here from the airport because their wound was bothering them. That's somebody you really got to worry about that could have rabies. That's not just another dog bite. So getting that history of where, when, who, what, why, how, even on a dog bite is extremely, extremely important. So wild animals in the U.S. account for 92% of reported cases of rabies. And raccoons of all animal cases are the highest percentage, followed by bats. And then skunks, foxes, and other animals, including rodents. There's a thought that rodents can't carry rabies. They can. They haven't transmitted rabies through a rodent bite in many, many, many years, but it's a possibility. We need to assess the situation. We'll get to a situational assessment in a little while, but I wouldn't rule out the bite of any animal as having the potential to transmit rabies. We need to think about it. Domestic animal data is interesting. In the U.S., domestic species accounted for 8% of all rabid animals in the U.S., and cats have outstripped dogs in their possibility of being rabid. And the reasons no one's really quite sure of are that cats are not usually as well supervised as dogs. They may be more outside animals than inside animals. Cats have a lot more curiosity than dogs do, so they'll bring you a dead bat, or they're inquisitive in that way. And cats are much more prone now to becoming rabid than dogs are, so you need to pay special attention to cat bites that you may not have in the past. The number of rabies cases in cats is routinely 3 to 4 times that of rabies in cattle or dogs. So when you hear cat bite, again, your antenna has to go up, and how did it happen, where did it happen, why did it happen, and we'll get more into that. Pennsylvania reported the largest number of rabid domestic animals from any state, followed by Virginia. So that's why I'm saying you need to know your local demographics and epidemiology. So if Jolene goes back to practice in Hawaii, she has less to worry about in her patients with rabies than we do here in Pennsylvania. But you need to know about that. So Pennsylvania is sort of a high-risk state. Now 1% of cats and 0.3% of dogs test positive for rabies. They do surveillance on animal populations, and that's the data for that. So as I said before, there's been a decrease in domestic animal rabies after World War II as a result of better canine vaccination programs, better veterinary care. In 1946, there were over 8,000 cases of indigenous rabies in dogs, 33 human cases. In 2006, there were 79 in dogs and 3 in humans. So we're lucky. We're living a charmed life here. But it's about to change, and I think we're on the cusp of a potential little run on rabies, and again, we'll get to that. Interestingly, one of those 3 cases was due to a dog bite overseas when people came back and then were diagnosed here. So never forget how well-traveled your patient population can be. And don't discount the folks in our area. They go on vacation, they get deployed with the reserves and the military, they do the same things everybody else does, So make sure you ask about where they have been and where this animal life took place. The risk for reintroduction from abroad is very important. Travelers are at risk for exposure from both domestic and feral dogs and cats when they're overseas. Very important not to forget about that. The primary risk for U.S. rabies, again, is wild animals, the most important potential source of infection in the U.S. Most cases are associated with carnivores like raccoons, skunks, or foxes, but bats are important. We'll spend some time talking about bats in a little while. The majority of naturally acquired indigenous human rabies result from variants of rabies viruses associated with bats. That doesn't mean you got bit by a bat, it means the virus developed in a bat. There are several different varieties of virus. And how it spreads to other animals, you know, who knows? A bat dies, a raccoon eats it, the raccoon bites a dog. It's a whole, you know, chain of events that happens. And you need to understand that. But again, the number of cases in the U.S. has been surprisingly low. In an article in 2004, one of the rabies gurus, Dr. Ruprecht, made a statement that I think is really true, and we need to remember it. The public may not appreciate that their surroundings are a veritable sea of rabies maintained by common animals. And you need to treat every animal bite as if it's from a rabid animal. You need to question that potential. And I'll tell you how we do that in a minute. But first, I have a rabies transmission quiz. I'm going to show you a picture of an animal. You tell me if they can and have ever transmitted rabies. The mongoose.
Yes.
Yes. Sheep.
Yes.
Yes. The North American bobcat. Yes. The woodchuck.
No.
Yes. The African gray parrot. No. The skunk, four-legged variety.
Yes.
Absolutely. The fox. Yes. The jackass. Four-legged variety, two-legged variety.
Who's the one on the right?
They both can transmit rabies?
Yes.
Yes, they both can, absolutely. And my favorite, the parrot.
Yes.
Yes. And who knew that there was even a magazine called Modern Ferret? You get that at home, don't you?
I do, actually.
Along with New England Journal? Okay. So, the cases of animal rabies, again, I can't overemphasize it. You need to know the local epidemiology, the local animals that you have to worry about, depending on where you're practicing. I'd like to give you a case study of a local area, Upper Marion Township. And the reason I'm doing this is because I live there. This is an area west of the city, covers about 18 square miles. It's about 15 miles from Center City, about 30,000 residents. Interestingly, the township expands about 100,000 on a business day. So a lot of people come in there to work and do business. Large parts of Upper Marion Township are covered with wooded areas, and we include a large percentage of Valley Forge Historic Park, which is over 1,300 acres of most of them developed land. And we have, as many of you probably know, one of the largest malls east of the Mississippi, or the largest mall east of the Mississippi, I forget. But this is a little inventory of the animal life in Upper Marion Township. We have white-tailed deer, they can carry rabies. We have fox, groundhogs, coyotes, believe it or not. Bobcats have been seen in Valley Forge Park. They've never been confirmed, but there are reports of them being seen. Plenty of feral cats and dogs, raccoons, bats, flying squirrels, and beaver. And that's sort of the bad news, but the really bad news is in 2009, the Upper Marion Township Animal Control Officer retired. And his position has now been eliminated, and this scenario has been repeated nationwide. And that's a picture of the van, which is sitting in the back of the Upper Marion Township building, and it's been unused for several years. And this position, Animal Control Officer, is what basically stands between our 3 cases a year of rabies and the tens of thousands of cases of rabies that are seen overseas. The Animal Control Officer is the person you call when there's a raccoon in your attic, or when, as happened to me a few weeks ago, I saw a fox wandering down the middle of the street, looking weird. And when I called the police and told them there's a fox walking down the street, they said, "Is he bothering anyone?" And I said, "Well, did he ask me for a cigarette?" But there's no one to attend to a fox who obviously rabid. If you see them during the day, they're probably rabid, but this thing was wobbling down the middle of the street. So the animal control officer, and the fact that as townships are tightening their belts now because of budgetary concerns, this is one of the positions that goes first, because it's viewed as, oh, you know, if the neighbor's dog is barking, they'll come over and yell at the neighbor kind of thing. But they do a lot more than that, and they are the ones who really surveil the townships, which is, you know, like politics, all politics is local, much of public health is local. And without animal control service in your area, this is going to be a tipping point for rabies to come back. Just the other night on the news, I saw a really wild thing in I don't know if you had any, Gateway Shopping Center. It's in a different township. It's right next to the township where I live. A gigantic white-tailed buck broke into the Sprint store and was running around, and then finally they opened the door and he ran away. But they had their pocket phones and they had video of it, and it was funny. But this is a potentially rabid animal running around a shopping center in suburban Philadelphia. So this is something that's, I think, going to happen unless public health starts to get the attention of boards, local boards, and supervisors, and things like that, so that these animal control positions are not eliminated, because, again, they're the last line of defense. So in the U.S., it's a staggering number, and this is with good animal control, up to 40,000 people come into contact with potentially rabid animals, and many of them receive post-exposure prophylaxis. Our job as healthcare professionals is to be able to assess the risk so that people don't get it needlessly, as this patient that we were tending to in the emergency department did. Prophylaxis is an urgency, not an emergency, so that you don't have to flip out when you see these patients, and you have to take a little time to make your decision and decide if they need it or not, and get some professional or expertise to help you make that decision. And the prophylaxis burden can probably be reduced with proper decision making. But again, I think it's a very emotional thing. If you think someone could have contracted rabies, rabies fatal disease, and there's no good treatment for it. So that sort of freaks people out when they hear that, and then an urgency becomes an emergency, and then people don't make good decisions. So when you see one of these patients, or the treatment, really the basis of the treatment is three very simple things: wound care, and in fact, cleaning the wound early on after the bite probably reduces the chance of spreading rabies by about 80%. That's an animal study. So people need to be encouraged to clean wounds. Local infiltration, if it's spelled correctly, of the rabies immunoglobulin and vaccination. And this triumvirate of treatment is uniformly effective when it's applied properly. So we've got a fatal disease with 100% ability to cure. But we just need to know when to do it and how to do it. And we'll